we're continuing, and we are continuing within the session of reducing inequalities, and we are going to talk about, the inequalities or similarities between the sexes about cancer, male or and female cancer. And I have the pleasure to welcome Peter Baker. He's representing is the founder of the Global Action on Men's Health in the UK. And we also have Helena Torsler Andersson from the Cancer Society in Sweden, and working as an expert in oncology. And I think we will have a presentation by you first, Peter,
yeah,
and
that's right.
Then we will continue this discussion. Go ahead.
Fantastic. Thank you very much. Right, if I could have my slides, please. Here we go. Good. Well, thank you very much indeed for inviting me to talk to you about men and cancer. It's fantastic that you've invited me and Helena to talk about gender and cancer, because it's a subject that's very often overlooked. So often we talk about cancer, but we don't talk about sex and gender differences or similarities, and that's obviously really important. So I'm going to start off, it's maybe a bit counterintuitive, but I wanted to start with a slide on women and cancer. This is from a recent Lancet Commission report on women, power and cancer that came out just a couple of weeks ago. And I wanted to show this slide because I think I'm not here just to make a case for men. I'm here to talk about gender primarily. Of course, there are different dimensions to that, men and women. But I think I want to make it pretty clear that I don't come from that part of the debate about men which blames women for all men's problems, or sees that this is a kind of binary issue where we have to choose between men's health and women's health. We don't. There are very serious problems in women's health, very serious problems with women and cancer that were highlighted by this Lancet Commission report. But there are also problems about men and cancer, and I think it's possible to think about both issues at the same time and to look about where we perhaps need different responses to meet the needs of both sexes. So turning to men, this is a report that my organisation, Global Action on Men's Health, published in June during International Men's Health Week. What we did, we commissioned some research to look at cancer policies at the international level to find out how men were addressed in those policies. And what we found was pretty much what we expected, actually, that men are largely absent from cancer policy as produced by the major cancer organisations. Not all of them, but most of them. So while typically in a report on cancer, you might have some sex disaggregated data at the start, may highlight a few differences, perhaps show that men are worse off in some cancers, less well off in others, but that's never followed through in terms of policy. It's never followed through to actually with any practical suggestions about what we do to tackle the excess burden of cancer in men. So just looking at what that burden actually is, and here's some data from Sweden, and you can see the source there at the bottom. This was a study of over 870,000 cancer cases in Sweden over, a 55-year period of time. And it found that male sex was associated with increased risk and poorer survival for the large majority of the cancers that affect both sexes. And men were at significantly increased risk for 34 out of 39 cancers and had higher mortality for 27 cancers. And this is, in the next slide, you can see in this chart the cancers in the top right box, which is most of those 39 cancers in Sweden. You can see that men are both at greater risk of developing one of those cancers and at greater risk of dying from one of those cancers. So there is clearly a significantly increased burden of cancer on men in Sweden, and that's also true internationally. This is global data which shows that men have a 19% higher incidence rate of all cancers, with particularly high incidence rates in Australia and New Zealand. and cancer mortality is 43% higher in men globally, and the highest mortality is in the Eastern European countries. And here you can see which are the most common cancers. This is incidence data, which shows the most common cancers in men globally. And the green box, the green countries are for prostate cancer. So in 112 countries, prostate cancer was the most common cancer in men, and lung cancer, shown in blue, was the second most common cancer in men. And if we look at mortality, this is mortality data, we can see that the most common cancer killer of men in blue is lung cancer, followed by the green countries, which is prostate cancer. So prostate cancer has become the most common cancer, and but lung cancer is still the most common cause of death in men. So the key question is, why is this? Why are these rates so much higher in men? And there are a number of factors, I think. The first and most obvious one is that men take more risks with their health. Men are more likely to smoke. That's particularly true historically, but it's still true the difference between men and women is less in many Western European countries now. But globally, men are still much more likely to smoke than women. Alcohol consumption is much higher in men than it is in women. Men tend to have a poorer diet. They're more likely to expose their skin to the sun without protection, and so on. So men are more likely to take risks. And they're also, in general, not all men, but they're generally more reluctant to seek help. So both these factors are related to masculinity. Men are generally not only risk takers, but they have to project this image of control, of strength, and invulnerability, and that makes it harder for a man, or many men, not all men, to actually ask for help when something might be going wrong. But that's combined with lower symptom awareness. Research that's looked at symptom awareness and differences between men and women has found consistently that men are less aware of the common cancer symptoms. And of course, if you're less aware of a cancer symptom, you're less likely to do anything about it. Because of the way in which occupations are gendered, men are more likely to do work that exposes them to occupational carcinogens. So, for example, firefighters, who are mostly male, though that's changing, but it's mostly a male profession, have very much higher rates of cancer than other professions. And the same is true of men involved in mining, in construction, and other dangerous occupations. Then there are health system access barriers. And there was a study published recently. It was commissioned by the Australian Department of Health, and it was an international literature review looking at the barriers men face in terms of accessing health services, particularly primary care. And it found there are some practical barriers that are most often related to men's work. So we know that men are more likely to work full-time, they're more likely to commute further distances to work, and this actually makes it harder for them to access primary care when they need it. So if you combine that with their reluctance to ask for help, it's a pretty potent combination. And there may be some biological factors as well that predispose men to developing some cancers because they have one rather than two X chromosomes, and therefore only one set of tumour-suppressing genes. So what can we do about this? This is the key question. Do we throw up our hands with a sense of fatalism and think men are biologically programmed to keel over at the age of 65? Well, I don't think so. I think we can actually do something about this. And the first thing we need to do, and it's been said many times today, is to collect and publish comprehensive sex disaggregated cancer data. We have a lot of this, but we still don't have enough. And it's still surprising to see so many reports and papers published about cancer which are not sex disaggregated. We need to include men in national cancer plans and in health policy generally. As I said at the start, our research has shown that men are largely not covered in cancer plans, perhaps with the exception of a few words about prostate cancer, but they're not addressed as a group which may need some special attention. And I also think this could be true of health policy. This is true of health policy generally. So if you look at cardiovascular disease, diabetes, a whole range of conditions which men are more likely to develop and to have worse outcomes, men are generally not addressed. I think it's very important, the fact that we also have national men's health policies. There's only one country in Europe that has a national men's health policy, and that's Ireland. And we have seen quite dramatic improvements in men's health outcomes in Ireland, which are at least in part related to the national men's health policy. And the WHO European region has a men's health strategy. Not many people know about it. It was introduced in 2018. All the member states signed up to it, but unfortunately, not much has happened in terms of its implementation. But there is a blueprint there which could be implemented. We need to improve men's engagement with primary care and screening services. We can do lots of things to improve men's access to primary care in terms of thinking about opening hours, appointment systems, and also taking services to where men are rather than waiting passively for men to come to use a mainstream service. But also screening. We could do a lot to improve screening. We heard about lung cancer screening earlier. I think that's really important, and we've seen from the map I showed earlier that lung cancer is a particular problem in men's health. But bowel cancer screening, we've had bowel cancer screening in many countries for many years. Bowel cancer is more likely to affect men, but they're less likely to use bowel cancer screening. But there's a lot we could actually do to improve uptake if we had an approach where services were marketed in a gender-specific way. We need to target cancer prevention initiatives at men and boys. Where this has been done, we have seen quite remarkable improvements in terms of improving men's symptom awareness and encouraging them to come forward if they have problems. In the UK, there was a campaign around bladder cancer, and basically it said if you see blood in your urine, you should go to the doctor, and it actually resulted in a large number of men seeking help because of that. We need to accelerate the adoption of gender-neutral HPV vaccination. Not only would that improve women's health outcomes because men wouldn't be passing the infection on, and we know that about a fifth of men have an HPV, a high-risk HPV infection, but it will also protect men against the cancers in men that are caused by HPV, and of course protect men who have sex with men who derive no protection at all from a girls-only vaccination programme. And we also need to look, I think, at prostate cancer screening much more actively. We heard earlier about developments in prostate cancer screening, and I think we now have an opportunity to introduce those programs on a much larger scale. Well, in fact, to introduce them in the first place at all. We need to focus on groups of men at greatest risk of poor cancer outcomes. So we need an approach based on proportionate universalism where we think about all men, but we think in particular about those groups of men who have the poorest health outcomes. So that will be men, for example, in the lower income groups. In the case of prostate cancer, it will be black men who are much higher at risk. So we can identify particular groups which need more targeted attention. And I think men and women's organisations should start to work together to ensure that cancer policy and practice takes full account of gender. That hasn't happened yet, but I think there's enormous potential for us all who have an interest in gender to work together. We started to do this on COVID, where we saw, perhaps for the first time, men's and women's organisations working together as part of the response to the pandemic, and I think we could do something very similar around cancer. Okay, so just a few words about what we're doing at Global Action and also in partnership with the European Cancer Organisation. And it's fantastic that ECO has developed a Men and Cancer work stream to help develop this work in Europe, and we're working in partnership with them on this. We had a round table in April last year to bring people together to talk about some of these issues, and a report on that, Men and Cancer Raising the Issues, was published July 2022, and you can download that and take a look at it on the ECO website. We also worked together on a Journal of Cancer policy editorial on men and cancer that was published last month. So again, it's on open access, so I think it's well worth taking a look at. And we're currently working on a Men and Cancer manifesto for Europe that will be launched at the EU Parliament on the 29th of November. So if you're in Brussels on the 29th of November, you'll be very welcome to come along to that. And Global Action has launched a global campaign on men and cancer, which has a particular focus on HPV vaccination and prostate cancer screening to try and move forward policy on this issue. So my final slide says, if not now, when? Or I could sort of translate as, let's get a bloody move on, because we've actually neglected this issue for far too long, and we actually need to start addressing it because we know we can do something about it. We can end and tackle this serious but not discussed enough health inequality. So thank you very much.
Thank you so much, Peter, and we will come back to you. But first, we will also listen to Helena, please.
Thank you for inviting me. I come from the Swedish Cancer Society, and we are an independent, and I want to talk about what we have noticed when it's about male and female cancer differences and challenges. We are a fund-raising organization, and to reduce the number of people affected with cancer and increase survival rates, we fund research, we inform about cancer, and we influence decision makers on critical issues. So, at the Swedish Cancer Society, we have noticed differences in how women and men handle and engage with cancer-related issues. And reaching out to men have presented a particular challenge for us. So where do we see these differences? Well, we can observe it in several ways. The Swedish Cancer Society operates a support hotline, Cancerlinjen, Cancer Line, where the general public, but especially patients and next of kin, can turn for answers and psychological support. In our 2022 annual report, we noted that our helpline had over 8,000 contacts through phone, email, and chat. Among these reaching out for us, 70% are women, and only 30% are men. And if you look at the persons close to somebody with cancer, it's only 20% male and 80% women. Most men are reaching out to us. It's a little bit different from what you said, but most people men who reach out to us, they have questions about symptoms and inquire much more potential cancer symptoms information than other groups. We also see that men want to talk about health anxiety, cancer investigations, and the structure of health care. While women often discuss incurable cancer, heredity, and grief, and they want to talk much more about emotions connected with cancer issues. And yet, we did a Demoscope survey 2021, and then we commissioned that men have nearly as much need for information and support as women have when they're diagnosed with cancer. We also observed in that survey that more than 1/3 of the survey male next of kin felt that they didn't receive sufficient emotional support from healthcare or their loved ones, despite having significant need for it. Through various campaigns like the Pink Ribbon, which is going on right now, our television show, as well as our website and social media presence, we aim to share stories from patients and their loved ones. This is very valuable to make those affected feel less alone in the situations. Last year, when we solicited people to share the stories, only 25% of the stories was received from men. This contributes to male cancer not receiving the same visibility as female cancer. A similar distribution is also evident in our Facebook group Together, where patients and loved ones can share experience and support each other. We also see it in engagement across our social media platforms. Our Pink Ribbon campaign, which we are running now for the 20th year, generates tremendous engagement from people across the country. Private activities and fundraising efforts ensure the campaign to gain significant visibility. It was much more challenging for us to create a similar engagement with the Mustache Camp, which is for prostate cancer. And it was labor-intensive to run 2 major campaigns one after another, since the breast cancer campaign is in October and the prostate cancer campaign is in November. But today, the Prostate Cancer Foundation runs the Mustache Camp. And I believe that the engagement among prostate cancer patients has increased over time. The diagnosis is not stigmatized as the same as it has been. And men are increasingly beginning to organize themselves, as, for example, breast cancer women have done for years. So, how do we reach men? Well, this is a question we have asked ourselves, for which we are still searching for an answer. We have organized some few activities addressed specifically for men, and let me provide some examples. We have had a webinar providing information on PSA testing and prostate cancer, as well as a discussion on why men are not routinely screened for prostate cancer. One urologist participated, along with a male actor, Stefan Sauk, who had battled prostate cancer himself. The webinar was promoted via email. We had some email address that we used, and social media. And we had approximately 150 participants. The majority of them were men. We have also had social media series on exercising and getting back into shape after cancer treatment. We recorded several videos with a well-known Swedish actor and comedian, Sven Melander, who is unfortunately not with us any longer. But the choice of Sven was made with intention to reach men. So, how did this work out? Well, we haven't seen that these activities have increased the male engagement. The number of contacts from men or engagement on our channels has not changed. And it's not very surprising, because we knew that men aren't very present in our social media. And at the same time, we didn't know how to reach them instead. Is it at a sports event? Is it on the beach? Or is it in the grocery store we can reach the male population? We really don't know. We haven't got the answer. Another question we have asked ourselves is whether the psychological support in healthcare and in helplines is more tailored to women. Often the focus is on support groups with a conversation partner, frequently a woman. When we have sought personnel for our cancer helpline, it's almost exclusively women who apply for the position, which is unfortunate. Could it be that men come together around different issues? An example is when we visited our sister organization in Denmark. They had an area across the Rikshospital in Copenhagen where they had gathered all the psychosocial support. And in that area, they had a house for men, where men with cancer or who were living with someone who had cancer met for various activities like carpentry or cooking. During these activities, the men could naturally start talking to each other. And my own husband expressed when I had breast cancer that he would like to connect with other men, but not in a traditional support group setting, which is often what is offered. Could it be that men prefer to engage in activities where conversation can naturally flow? There are several different reasons why cancer in men is not as prominently recognized as cancer in women. And the causes, I think, can be found both in society and among men. So, what do we need to do? Well, I'm convinced that all of us working on cancer issues need to learn more about male cancer and cancer in men, and how men cope with being diagnosed with cancer or being close to someone with cancer. We also need to learn about how to reach men with prevention messages to reduce the number of cases and how to encourage men to seek healthcare earlier, so that more cases of male cancer can be detected at an earlier stage. Thank you.
Thank you so much, both of you, and please stand by me. and I think I hope you all think this is very interesting to see and to learn from, because I think in some way that what you have told us is really what we have been thinking the statistics would be, or something like that. But really to see it on the screen, it really demands for action. And just a short story. I have a friend who told me some years ago that he and his wife were often asked why they only had one child. And that, I mean, that's not uncommon to have just one child, but somehow they had been asked several times during the years, and at first he was very, uncomfortable with the question, but over the years he learned that he should be more open with the reason why they just had one child. It was because when his wife got pregnant, just a few months after the message that she got pregnant, he was diagnosed with penis cancer. And that was actually the reason that they could not have any more children. And when he was starting to be more open to talk about the reason, he was also, he said that he was he got so many more engaging, comments also, and interested comments. People wanted to learn more. And you said, Helena, that you don't have the answers how to reach out to men.
No, we don't.
I think Peter is also trying to reach out for more kind of actions or activities, really. But as we have seen the statistics and results that you have shown us, is there anything, that has been tried somewhere that you at least could give us as a very good example? Is there any campaign somewhere that has reached out locally or nationally that you have really seen at least there? I mean, maybe we cannot copy everything, but to have some good examples.
Well, I think we do have some good examples from around the world now. Over the last 30 or 40 years, there's still not enough, but there have been, nevertheless, lots of examples where people have tried different things to engage men, particularly around prevention. So we know, for example, that we can do things that improve men's lifestyle in terms of weight management, smoking, drinking, diet, those sorts of issues, often by taking services or initiatives to where men are. So, for example, you mentioned sport. We know there have been some very successful programs that have used soccer, rugby, and other sports, hockey in Canada, for example, to actually reach men and to get them engaged in programs that improve their behaviours and lifestyle. So we know that can work. Taking services to workplaces, particularly male-dominated workplaces, and some large employers of men have been interested in this in construction, in transport, and other industries. They tend to work well because if you take a service to men into an environment where they feel more comfortable, you are a lot more likely to get engagement. So those kind of approaches seem to work. You also mentioned, I think, quite rightly, engaging men while they're doing, perhaps involved in other kinds of activities. And we've seen, I don't know whether you have them in Sweden, I think you may have some, men's sheds. These are kind of community workshops where men come together to take part in typically craft activities, usually older men in their 60s and older. It's very big in Australia, in the UK, in Ireland, and some other countries. Germany, I think, is beginning to see them develop as well. So when men are kind of shoulder to shoulder rather than kind of eyeball to eyeball, often you can have these kind of conversations, or you can use that setting as an opportunity for talking to men about issues like prostate cancer or other cancers they may be concerned about. So there are a number of things that we know work, providing confidential helplines. I know your experience maybe wasn't great, but we know from other contexts that approach has worked well. So men don't have to go to the doctor straight away and have a kind of embarrassing conversation. They can actually do something anonymous and confidential to start with, and that kind of gives them then permission to take the next step. So we have got some good ideas and things that I think need to be tested and tried on a larger scale.
Good to hear. Mm-hmm. But I think when you showed us, Helena, about the differences in topics that men and women bring up at the cancer line, that women are more talking about emotional things like grief, for example, or something else. But I mean, nowadays, I think young fathers especially, they are very keen on having good contact with their children. They are following from their babies and upwards, and I think, I mean, it should have been changed in a way. Also, grandfathers are more involved in family life nowadays. How do you think we can change that? Because I guess that men must talk about more emotions as well, to really bring out also the fears and anxieties.
I think it will change. I think it's a change going on right now, according to age, and so I think it's going to change. And the men who's calling the cancer line often have some medical question at the beginning. So they get registered as they have medical issues. But when you pick on them a little and talk a little, they often goes over to talk emotions as well. But the main reason they contact us, I don't know if it's so or if they just want us to think it so. They have questions about symptoms or statistics or something like that. But when you talk to them for a while, you can talk emotions with them as well.
Maybe it has to start somewhere. Yes.
I think information is often what men want first. They want the facts, but put it crudely, rather than go straight in talking about emotions. But when they feel safe and more comfortable, then that can be an opportunity for men to open up more about how they actually feel about what's going on. But it can take a bit of time.
We have to stop now because we have fika, the Swedish word for coffee break. And that's just as important for Swedes to have some coffee, and I guess for others as well. So thank you so much, Helena and Peter, and let's also talk to them during breaks and maybe tonight also to hear more and to learn more from each other. So thank you so much.
Thank you.
Thank you.
And we'll be back here at 4:15, so you will really have a good coffee. Thank you.